Good afternoon, everybody. Dr. Randall Wolf here. It's the first Tuesday of the month, 5 p.m. Central Time. Time to talk a little bit about atrial fibrillation. We do these DeBakey CV Lives the first Tuesday of the month, except for the summertime when the producers get a little lighter schedule. And we will have a conversation with one of my patients today, who I'll introduce in a minute. He's been kind enough to join us. I know was in South Dakota when he first came to see me, but he also has a place in Florida where he is now, so he's a wise man. I think I would probably get out of South Dakota in January also. We will end this session about 5:45. As usual, you can join us, and I encourage you to do so. It's a great time to ask questions about AFib. There are no stupid questions, so don't worry about that. If you have a question, you have two ways to join us. One is with your phone. You can text DeBakey, and the number is 37607, and then you put in DeBakey and text us your message. If you're on a regular computer, you go to pollev.com, enter DeBakey, and then ask your question. There usually is some limit on the number of spaces you can have, I think, on the text, so you may have to make it a little bit brief. Also, if you happen to join us after the fact, so we are not live, you still have an opportunity to ask us a question. You can ask the question, and we'll answer it at the next session, which would be a month from now. However, it makes more sense if you can ask your questions live, because both my guest and I will be here. Next month it will be me, but it'll be a different guest. But that's okay. If you're joining us after the fact, then you can still submit your questions. I wanted to address one other thing. I got a call from Sandy Schremeyer, who's the administrator for the Facebook site, Live AFib Free Wolf Procedure. And she mentioned to me that we have now over 4K people on that site, which is great, a lot of good interaction. But she was concerned about one interaction. I thought I'd take a minute to explain it. I don't monitor the site, but Sandy, as the administrator, does. She brought this to my attention, so I thought I'd try to straighten it out. As usual, on the Facebook site, some things are left out. I don't think deliberately, but patients oftentimes leave things out. This was about a patient who had the Wolf procedure not too long ago, and he or she, I won't say which for HIPAA concerns, but he or she did not want to take the amiodarone preoperatively, which we had recommended. So usually we start low-dose amiodarone for 60 days before the procedure. And based on my experience over 23 years, it's extremely beneficial. It decreases the chances of atrial arrhythmias right after the procedure. Right after the procedure, there's inflammation. It doesn't matter whether you've had your appendix taken out or your gallbladder or your knee replaced. There's always inflammation after a procedure. And in the case of atrial procedures, that inflammation can also cause atrial fibrillation or atrial flutter. And we've found that that's pretty much tamped out if amiodarone is taken once a day for 60 days before the procedure. It's a low dose. It takes almost 60 days to get enough in the body for it to be effective, so it works out about right if it started 60 days before. This patient refused that, and then after they went home to another state after the procedure, they had an episode of atrial arrhythmia and went to the ER, which is fine. The ER called me. This was also not in the Facebook note, but the ER called me and I responded. I called the emergency room where this patient was being seen, and the ER doc seemed quite reasonable, and they were going to start amiodarone, but you can imagine it's kind of hard to catch up when the patient hasn't taken it for the 60 days, and now you want to get them all loaded up in one day. Not ideal. Additionally, the ER physician suggested maybe they could do a cardioversion there in the ER, which I thought was a great idea. And unfortunately, the patient refused that as well, which was not in the email. The patient then was discharged and came back to the ER, and it was reported that he had arrhythmia again and that he had flatlined. Well, in fact, he hadn't flatlined. This is something important to explain to everybody who's suffering from AFib, and that's the point of this little presentation. There are two ways to cardiovert the heart. One is with electricity, and we've all seen it on TV where they take paddles, and the paddles are applied to the skin, and there's a shock given, and it requires anesthesia. There's another way to cardiovert, and that's your body cardioverts automatically, and that happens quite often. And some patients will report that they have an episode of AFib, and they get real dizzy, almost pass out, but they don't. Well, that's when they cardiovert themselves. Their own heart has a pause. It resets the electrolyte channels, the sodium and the calcium, all balance out, and then the heart beats again. And that's called a compensatory pause. A compensatory pause. It's natural, but during that compensatory pause, either initiated by the patient's own heart or externally, for a few seconds, there's no blood being pumped around the body, so there's less blood to the head, and the symptoms are dizzy, syncope, feeling like you're going to fall down, pass out. It's not dangerous because it's really your body resetting your heart, which is a good thing. And it turns out this particular patient had been experiencing that for several years before the procedure, and he did it also after the procedure. So just to be clear, that's not flatlining. That's a normal, natural compensatory pause, which is a pause, so it can cause lightheadedness. Pre-syncope is what it's called in the emergency room. So in my opinion, if you have AFib and you have that dizzy feeling and your heart resets and then you're back in rhythm, that's a good thing. It's not a bad thing. I know it's a little scary, but it's a good thing. I'm going to take a question before I introduce George. Can the mini maze be done for slow AFib or for frequent PACs and not just AFib? The Wolf procedure decreases the autonomic nervous input to the outside of the heart. These nerves are on the outside of the heart. So any type of AFib, it will help. Slow AFib means that your own body's response is to have a very slow heart rate, and oftentimes that's influenced by the medications that the patient may be on, such as metoprolol, a beta blocker. It will slow the heart down. It will slow AFib. It does not usually allow the heart to change from AFib to sinus. So it's not a real antiarrhythmic drug, but it will slow the response, which is a good thing if the heart is too fast, which it often is in AFib. So untreated AFib is often treated with a beta blocker. There are certain antiarrhythmics that are also beta blockers, like sotalol. Sotalol will slow the heart. And if you're in AFib and you take sotalol or a beta blocker, your heart rate will be slower. Unfortunately, sometimes it gets below 60, and sometimes patients are told you need a pacemaker. Well, if you're not passing out, I don't think you need a pacemaker, whether your heart rate's 50 or 45 or 60. So keep in mind, just because your heart rate's less than 60 doesn't automatically mean you need to have a pacemaker, particularly if you're on one of these medications. The first line would be to decrease the medications that slow the heart. Now, frequent PACs are different. These are premature atrial contractions, PAC, premature atrial contractions. This is not AFib, it's not a flutter. These are truly extra beats. And the procedure that I invented was not invented to treat PACs, and I don't recommend it just for PACs. The PACs may get better or worse, but the procedure, the Wolf procedure, is not for specifically PACs. This, George, just put the sign up again. If you'd like to join us with a question, please go to 37607 on your phone, text in DeBakey. If you're on your computer, go to POLLEV.com, enter DeBakey, and enter your question. And please get your questions in before the end of the show. Now, it's my pleasure to introduce George Scone. He had AFib. He had the procedure, and I'd really like George to tell you his story, because I think some of you may be able to relate, or some questions may come up as he tells his story, which is fine. You can ask questions to George or to me or to both of us. So George, thanks for waiting for that long introduction. Welcome to the program, and you are doing your good deed for the day by voluntarily coming on and spending a few minutes with us. Welcome.
Thank you. Well, I guess you hit the nail on the head. The long introduction is one of the reasons that I like you, because you're always teaching me something. You're straightforward. I'd like to just formally say thank you first for what you did for me 6 years ago. Obviously, the operation. Bigger than that, I guess I want to thank you for being an innovator and just doing things different and getting better results.
Well, thank you. I appreciate that.
Yeah. And I mean that. I put a lot of thought into that, and a lot of the things you did as far as inventing and streamlining, I think is just amazing. I also want to say thank you to DeBakey, Houston Methodist. My experience in that system in the hospital was awesome. And I really appreciate the care that I was given. The other thing I kind of want to get out of the way too is, you already addressed it, the Facebook group with 4,000 people. I think that's just amazing. Thank you, Sandy. You are awesome. I can't say enough good about you and the people on the group. Very kind people who are just trying to help others. And I appreciate you acknowledging that there are bumps on the road. That's part of it. So anyway, my story.
And before you start, can you tell everybody what your business was, or what you did, what you were doing?
Okay, I was in telecommunications for 36 years. I think another 2 years if you count overtime and call outs and all that stuff. And that involved the early years. I started working for a phone company, fiber, and then that migrated into internet, and the internet ended up being all-time consuming, and that's pretty much what I did the majority of my career.
Okay.
Starting up with dial-up and ending with fiber to the home, which is, pretty awesome technology.
Yeah.
And so I guess my story is 25 years before I had the operation, which would, I guess, be about 36 years ago, I ended up with AFib. And, at the time, it wasn't easily diagnosed. And it was kind of it was a tough road for a while. Once it got diagnosed, then at least I kind of knew what I was fighting. But still, then at that time, there were no Facebook groups, there were no help groups that I was aware of. What I noticed is, since it wasn't immediately life-threatening, um, there really wasn't a lot of interest in the way I was feeling. So for 25 years, I basically dealt with it. I had probably on average once a month episodes. Obviously, they weren't once a month. AFib comes and goes when it pleases. So, I could have three in a month and I could go maybe 2, 3 months without it. I fought really hard trying to stop the triggers, fought real hard trying to cure it naturally, trying to cure it on my own. Um, and I guess during the early years, all I can say is it was a real lonely, desolate place without a lot of hope. Um, so, and during that time, I probably only spent 2 months on drugs.
Okay.
So, one thing that'll come up is before the Wolf procedure, I did not have an ablation. And I only really tried a few drugs that were ineffective or made things worse.
George, would you
And
say the frequency of the events increased or the duration of the events increased or both, or were you more worried about an AFib stroke? What was going through your mind then?
well, um, I I'm guessing they increased a little bit, but during that, I think the lifestyle changes made a little bit of a difference. If not on the actual AFib itself, just on the severity of how the episode felt.
Hmm.
One thing that I discovered very early on, which really helped, was I figured out how to self-convert. That was huge.
What was it
So
again?
I figured out how I could self-convert back out of AFib.
What? Share that with us.
What I found is probably year one, year two that I had it is if I exercised at a high intensity and got my heart rate roughly up to or a little bit over my AFib rate for even a brief amount of time or 5 to 10 minutes, it would either snap out of it or over the next day go down on its own.
Did you get
And,
dizzy when you would snap out of it?
um, well, I tell you, getting your heart rate up to 150, 160 when you're in AFib, I can't say I was ever dizzy or faint, but it was really close to like the end of the world. It was very hard.
Yeah, yeah,
Um, very, very hard and trying. But for me personally, it kept me out of the emergency room. It kept me out of the cardio part. I was never cardioverted.
hmm,
And I'm pretty sure I can say I was never in AFib for longer than 2 days. Um, Towards the end, I think you're getting at, was it getting worse? It might have been sticking around a little bit longer, but I was just at the end.
yeah.
I tried everything I could personally do lifestyle wise, and I was at the point where I was close to retire. My family was pretty much raised. My family was going to be okay if something happened to me, and I just said, I'm going to do something now.
Okay.
I had a list of about 100 things of not to do that triggered AFib. And I was going down the road one day and I took a sip of water and I went into it and it's like, I'm done.
You can't
This
stop
is
you can't stop drinking water.
well, with me, I would try as long as I could to stop AFib. So so at that point, I made up my mind. I found what I heard was the best ablation surgeon and uh, set a time, set a date. And in the process of seeing that, I went to the Stop AFib or the Get in Rhythm, Stay in Rhythm session.
So you
And
went, did you go to Dallas in person?
yes,
Okay, this
yes,
is the
and
annual
that
event. Now, some people may not know about this. This is an annual event, Stop AFib. It's really a 2.5, 3-day event put on by Melanie Truehills, who also did have a wolf procedure years ago, probably, I don't know, 20 years ago. Um, and she invites a lot of electrophysiologists and 2 surgeons for her event. And it's informative, isn't it, George?
yes, it's amazing, and I can't say enough good about Melanie. Thank you so much for what you do. She spent a little bit of time actually talking to me a little bit while I was trying to figure out. I actually went to a couple of different centers. I think I went to Mayo and I went locally, and I really did do the research as far as the statistics, as far as the success of the ablations and stuff. But I can't say enough good about her. As far as the that get in rhythm, stay in rhythm, that's if you have AFib, you really need to go to that. You need to just be around some of them people that are experiencing it, that have experienced it. Obviously, I got to hear you talk, which made a difference. But I'll tell you what was the craziest thing, and through the grace of God, I went to eat one night and there was an open chair at a table. And I sat down at that table and it was all people who had had your surgery, all people who didn't have AFib, who went to the AFib conference just to thank you.
Okay.
And it was like the most amazing thing. I sat with them and I was really taken back as far as, they shared with me why they decided that and how it went. And I can't thank them enough. So,
Yeah, these were, again, these were people that had been to the conference, decided to go at the time called the mini maze route, and they had the procedure, and then they still came back to the conference, which
yeah,
is
they, they,
amazing. I mean, I guess
they,
just to spread the good word.
yes,
And you just
yes.
happened to sit next to them. Just,
Yeah,
yeah,
yeah, one open chair.
yeah.
And that was the difference between the course of action I took from that point on,
Wow.
you know.
Yeah, that
So,
chair was meant for you, George,
yes,
I
it
guess.
was.
And that would have been back in 2018 or 19?
I was thinking about that. It could have been 2018, but it was most likely 2019. When I decided to move, it was fairly quick.
Okay.
So,
All
yeah.
right. And well, carry on. I interrupted you, but carry on.
Well, really, that's about it.
Well, tell us about
I
the procedure and how you did afterwards. I guess you stayed in Houston for about a week afterwards, saw him in the office, and then maybe flew or drove home.
Yes, yep. My wife and me flew down, I believe on like a Saturday. I think we had our appointments on Monday, and then the surgery was Tuesday. Um, it was it was a harder procedure, and I think everything went well, but it was a harder recovery for me
Mm-hmm.
than I thought it would be.
Mm-hmm.
So there again, I do it again. Um, uh, but when I went through it for the shape I was in when I went in, I did expect maybe it would have went. The surgery went good. Overall, everything was good. I mean, physically, I think within that week, even while I was there, I was walking a mile, 2, 3 miles. But the only way I can put it, and I think you mentioned this, is my heart was really, really angry.
Yeah.
And And I don't know if you remember, but I still had AFib afterwards.
Yeah. I don't
So,
think, I think that's back when I didn't put everybody on amiodarone pre-op. I might not have done that for you.
no, we didn't. And when you were talking earlier, I was wondering about that. There was a very good chance you meant, no, even if you had asked me to, I would have probably struggled with that.
Yeah.
It was very hard for me to take that drug,
Yeah.
but I finally said to myself, if I trust you to operate, I gotta trust you for what I take.
Yeah.
And
For
uh,
the
and and
protocol.
I and I thank you for that because I do believe that was instrumental in my recovery.
Okay. And
Yeah.
since then, it's been now about 6 years. Is that correct?
Yes. Yep.
Well, where are you now?
Well, I am AFib free. You asked me before we got on here, if I ever think of AFib. Sadly I do. I mean, I spent 25 years with it, and it's just kind of one of them things where I'm not living in fear every day of it returning, but it is a possibility. I'm still in lifestyle changes and trying to avoid it returning. But um, I'm at the point where I'm almost taking it for granted now.
Good.
To
That's
where,
good. That's good.
it's not always over my shoulder, Like about 3 years ago, I was thinking, wow, this is the first time I can remember not taking AFib with me on my vacation, you know.
Yeah.
Um,
Yeah, that's great.
so
Let's take a couple questions. Um, if the cause of AFib is from vagal nerves, gut issues, can that start new pathways for AFib again after the procedure? I guess, in other words, can the nerves sort of grow back? And we've looked into that, and nerves may grow back, but they won't be functional because the main body of the nerve, the neuron, has been destroyed. So it shouldn't grow back. You can have AFib come up in a different spot. That's certainly possible. And we have seen that from time to time. In my opinion, what caused the most AFib to come back in patients, I was just talking to one of these patients over the weekend. He's from New Jersey, and his procedure was about 20 years ago. But when COVID hit, he either got COVID or he got the vaccine, and he went out of rhythm within 2 days. He's back in rhythm now, doing fine. He required a cardioversion, but I saw patients that were 12 years out. At that time, he was 14 years out from the procedure, and it just proves that the COVID infection or the vaccines can cause significant inflammation of the heart, called myocarditis. And that was being mentioned during the pandemic, that they were seeing cases of inflammation of the heart or myocarditis. So it makes sense in some patients. It was so severe that's enough to pop them back out of rhythm. But he got cardioverted and he's fine again now. So I don't think these nerves grow back and work. You can have a new spot. You can have a severe inflammatory situation. I've been doing this way too long, so I've seen some anecdotal things happen. There have been several patients that had been AFib free for years after the procedure, and then they had a dental procedure where they injected epinephrine into the gum along with the numbing medicine, because the epinephrine causes vasoconstriction, the arteries clamp down in the gum, and the anesthesia lasts longer, so it makes sense. And as soon as they got the shot, they went out of rhythm. I mean, like that. So that's another very, very strong factor. So I recommend to patients who've had the procedure, who have AFib, if they need a dental procedure, you might want to try to avoid the epinephrine or the norepinephrine. It doesn't have to be given with the shot. And that's certainly been a trigger for a few patients after they've been off everything and doing fine. Not everybody, but everybody's wired a little differently. When you tie off the left appendage, it's another question, how does that affect someone with sodium balance issues due to no adrenal function? Well, I think what you're getting at here is the fact that the left atrial appendage has some hormonal activity, and it can stimulate your kidneys to hold on to water or get rid of water. When we close the appendage, we also open it so it doesn't have any pressure in it. So it really shouldn't change the sodium balance. And there was one study done, it was an electrophysiology study, where some of the patients had the appendage completely closed with the lariat and essentially tied off in a way. And the others had the Watchman, which is more like putting a cork in the bottle. So the appendage still had blood in it and it was still distended. And the patients who had the lariat had lower blood pressure post-op than the patients who had the Watchman, where the appendage really wasn't closed off, just had a cork in it. So what we do is we close it off and we open the tip to let the fluid out, the blood out. So it really shouldn't affect your sodium balance any more than baseline. Here's another question. By the way, again, let's put it up there one more time. If you'd like to join us, these are all great questions. If you have a question for George or for me, you can get on your phone, 37607, text in DeBakey, or if you're on your computer, you can go to pollev, that's POLLEV.com, enter DeBakey, and ask your question. Excuse me, another question. I'm new to AFib. A Zio monitor, or a Zio patch is what we call them, showed I was in AFib 5% of the time. Cardiologist put me on diltiazem and Eliquis. Diltiazem is a calcium channel blocker, by the way. It will slow the heart rate, and Eliquis is a blood thinner. I couldn't tolerate diltiazem, so he changed it to metoprolol. That was better, but I still didn't have the energy I used to. If I took a morning walk, I couldn't do anything physical the rest of the day, so I focused on mental activities. Since it was a low dose and my blood pressure wasn't high, he said I could stop the metoprolol. I finally felt like myself again. Eliquis gave me tinnitus or tinnitus so bad, it's ringing in the ears. I had trouble hearing those around me. My hips were also extremely achy at night. Doctor said I could stop that to see how I felt. I could hear again and sleep through the night pain-free. He wants me to start Xarelto. This is another blood thinner in the same class of blood thinners. I'm hesitant since I haven't had much success with the other drugs. And you bring up a very good point. And I figured this out. I'm a slow learner. It took me a while. But patients were coming back to me and saying, Doc, I feel better than I have in 10 years. And I thought, well, okay, you're in rhythm now, but better than you have in 10 years? You know, what's going on? And it finally occurred to me that I think about half their symptoms were due to the medication they were taking, and half their symptoms was the AFib. So once they got in rhythm and got off these medications, such as the beta blocker, the calcium channel blockers, the antiarrhythmics, which can make you very tired, and the blood thinners, yeah, they felt a lot better, a lot better. So I think it's a combination of both. And as I said before, everybody's wired a little differently. So some people can tolerate a large dose of a beta blocker. Other people can't even tolerate a small dose. So what would I recommend to this patient who asked this question? I would use an implantable monitor. I use the Link device, LINQ, from Medtronic. I put in probably 5 a week. And it will record an EKG every day for 5 years. It also sends that to us so we can see it. It also calculates the percent of time that the heart's out of rhythm per month. And 5% is a fair amount. And if you're symptomatic with that, that's kind of a point where you might consider doing something about it. You don't have to, but the link will give you a month to month, so you can really get a good idea over a few months of what your burden is. And if you're very symptomatic and you don't tolerate medications, then you have two other choices. One, catheter ablation, or two, Wolf procedure. So I would recommend you have the implantable device called a loop recorder, and just watch it for a few months and see where you are, and it will help you make a decision based on very objective evidence, i.e. what the link tells us your heart's doing. Does that make sense, George?
Oh yeah, yeah, and that's the thing I love about you, Dr. Wolf. You are truly an educator. I appreciate that so much. What the guy was asking, well, you had talked about dental. You hit the nail on the head there.
Really?
When I have dental work done, I either read or I noticed personally that it affected my heart rate. I wouldn't say it put me into AFib, but I'm pretty sensitive to knowing what my body is doing. So when I go in, I don't know the name of it, whatever you called it. I don't get that. They give me something else.
Yeah, it's
And
epinephrine.
yeah,
Epinephrine is in your body. It's stored in your adrenal glands that sit on top of your kidneys. And epinephrine is squeezed out when you're in a very stressful situation. So it also you can also make the inference that if your epinephrine levels are high, a lot of stress, you're more likely to have AFib, both from the
yeah,
epinephrine from your adrenal glands that sit on top of your kidneys, as well as your brain telling you that it's a stressful situation. So that whole stress thing is both from the autonomic nerves and how they interact with your adrenal glands. So getting epinephrine from an exogenous source, such as a needle, right into the gum, which is a very vascular area, that'll do it. For some people, that will do it. And they'll tell you, they got the injection within a minute, they were out of rhythm. So
real
it's
good point. And my
epinephrine,
dentist,
or shortened, some people just call it epi, E-P-I, epi. Here's
and if you
another
ask your
question.
dentist,
Oh, go ahead.
no, go ahead. Take the question, please.
Is having low blood pressure a problem with this surgery? No, it is not. That's fine. The surgery takes about an hour on each side. It's under a general anesthetic. Patients are awake at the end of the procedure. And what we started during the pandemic was not taking the post-op patients to the ICU, which I had done for 20 years, 18 years. We trained the recovery room nurses. We trained the nurses on the floor. So routinely now, patients go from the operating room to the recovery room to the floor. And I think, George, when you had it done, we were still taking everybody to the ICU overnight.
I don't think I went there,
You don't think
but
so?
I
Okay.
I don't think so. I
Well, maybe
I don't remember
we'd
that
switched
part.
it over, but we wrote an abstract. My fellow wrote that. It's probably going to be presented at one of our international meetings about how this procedure is minimally invasive enough that there's no change in the outcomes if we avoid the ICU. So that's nice. By the way, I wanted to mention too, I know patients routinely send me messages that we are a year out. We're not a year out anymore. We work very diligently in 2025. We got it down to a month. We're only a month out. So if you're thinking about having a consultation with us, go ahead and do it. And it's only about a month, wait of a month to have the procedure, which we're very proud that we changed that. And if you want more information, go to the Wolf Procedure, which is a website on the internet, WOLF, Wolf Procedure, and you can find out how to get a hold of us, or you can call 713-441-9342. That's 713-441-9342. That's here at Methodist Hospital, DeBakey, and we are at the Texas Medical Center in Houston. Let's take another question. Is feeling like your heart is in your throat and a fluttering of throat, and also feeling of bubbles coming up from your throat symptoms of AFib? Is this the gut connecting through the heart? George, did you ever have that? It's feel like your heart's in your throat, fluttering in your throat, bubbles coming up from your throat.
No, I think it's different for everybody. With me, it was like somebody turned a key and my heart rate immediately doubled.
And you felt that?
Oh, yes, instantly.
So we did a study years ago. I think we published it in 2007. We had people keep a diary while we monitored them for 48 hours. And they wrote down when they thought they were out of rhythm. And it turns out they were right only about half the time. But if you look at it more closely, there were certain people, I guess like you, George, that knew exactly when you went out and exactly when you went in. And that was about 50% of the people. The other 50% didn't have a clue. They might have felt tired, fatigued, couldn't go up a flight of steps as well, but they never had that feeling. So
Yeah, the person who asked the question, I'd recommend maybe getting a cardia if you wanted to talk about the cardia or
yeah,
some of the.
the incidence of AFib is increasing, but it's multifactorial. One is because there are more older people around, although the youngest patient I did this procedure on was 15. And I've done many patients in college and in graduate school. But generally it's more common in elderly people. But the other thing is what you mentioned. People are now using their Apple Watch more. We didn't have those 20 years ago. They use the Kardia, K-A-R-D-I-A. You can get that on Amazon for about 70 or 80 bucks. They'll have it at your door if you're Amazon Prime in 24 to 48 hours. It works through an app on your phone. It will record an EKG. You can send that EKG by email to your physician. That's the Kardia, and then there are other devices too. So there's a lot more awareness of AFib, and there is an increased incidence of AFib. So if someone has the fluttering in the throat, the next thing to do is monitor, either with an implantable monitor, the Link, which I mentioned, or the Kardia, which George mentioned, or even the Apple Watch, and see if irregular heart rhythm correlates with this feeling you get in the throat. If it does, then that's your AFib equivalent symptom for arrhythmia. Is my procedure a good choice? Yes, it's one of the choices you have. Again, you have medications. George didn't want that. And for good reasons, as that other patient mentioned, medications aren't very well tolerated sometimes. 2, catheter ablation, and 3, the Wolf procedure. Those are all options for people that are looking for what to do. And I think what George did was appropriate. You did talk to your electrophysiology consultants. You then did talk to me, so you saw the different options that you had. The one thing that I wish more electrophysiologists would do would be to mention all the options that are out there instead of just the options that they might happen to do. But in general, it's medication, catheter ablation, or minimally invasive surgical procedure. I think we've gotten through most of the questions. Again, if you have questions and you're seeing this after the fact, here's another question. Well, I'll throw it in there. I had an ablation 1 year ago. I still have AFib episodes. Yeah, welcome to the club. That's very common, and it's very common for electrophysiologists to rightly say it's going to take 2 or 3 before we get this. unfortunately, I see patients that have had 7 and 8, and the only thing is they're worse off than they were before. And I think it's because that technology of ablation is trying to burn the inside of the heart, and it doesn't get to the nerves, which are on the outside of the heart, which is what we focus on. George, I want to thank you for coming on. We didn't have the graphic for your email. You were kind enough to say if someone wanted to contact you, they could. Do you mind stating your email a couple times slowly in case someone wants to contact you personally?
Yes. Yes, it's GEOMAR86@gmail.com. GEOMAR86@gmail.com.
Thank you for coming on. You did your good deed for the day, and your random acts of kindness will be appreciated. I hope you have a great 2026. And gosh, maybe I have to come see you in Florida when I'm down there visiting my daughter. Well,
You're
last,
welcome anytime.
yeah.
I will buy you the biggest steak you want.
All right, that sounds great. Thanks everybody for listening in. We'll be back again first Tuesday of the month, which will be in February. Until then, everybody have a safe, happy, and prosperous 2026. Thank you. Thanks, George.
Yep. Thank you, Dr. Wolf.